So, good morning, all of you. Myself, Dr. Shubhopriya Chakraborty. We would be discussing with you all fever with rash. This is a very important topic for the clinical aspect as well as for the normal MBBS going people. So, these are the questions that comes to our mind. Fever is a clinical manifestation of several disease processes. Almost everything presents with fever. But sometimes it becomes very difficult for the clinician to come to a diagnosis. And when a rash is present along with fever, it gives us a very important clue that helps us comes to a diagnosis. So we would be discussing those things, the specific fever with rash manifestations that are very important for us for the clue part. So let's come back to the basics. Macule and patch. Macule is a flat thing that increases in size to become a patch. Papule is less than 0.5. It is elevated from the skin surface. That is a papule. And when a papule increases in size, it's known as a nodule. Plaque is something, a very irregular part of the skin which manifests as a plaque. Vesicle and bulla. Vesicle is something which is a smaller thing, and when it increases in size, it becomes bulla. The vesicle gives rise to a bulla. Pustule to an abscess. So let's go to the differential diagnosis of fever with rash. So these are the things. Let's come to the most important thing: maculopapular rash. So macular means a flat thing, and papular means it is also elevated. So macules are those red-pink surfaces, rashes that are flat areas, and very importantly, they blanch on pressure. They blanch on pressure. And the papules are somewhat elevated. They are solid, raised rashes, hemispherical lesions, and they also blanch on pressure. So there are various diseases in which we can get maculopapular rashes. It can be measles, it can be rubella, in which we get that salt and pepper chorioretinitis. Rubella is also a part of torch infections. Exanthema subita. This is the classical, also known as roseola infantum. Epstein-Barr virus that causes infectious mononucleosis and the dengue rash. Bacteria such as post-streptococcal, as we all know, can cause maculopapular rashes. The scarlet fever. That scarlet fever has a very typical pattern in which they produce a lot of sandpaper-like rash, and they also are very important to have that strawberry tongue. So this can also have that maculopapular rash. Syphilis, leptospira, Lyme's disease, which is very popular in the UK part. Europe has got a lot of Lyme's disease caused by Borrelia. Coming to the rickettsia. The rickettsias can also cause maculopapular rashes. And let me tell you guys, rickettsia, nowadays it has become very important. Like when we are getting a fever with rash which is not getting controlled with a lot of normal empirical antibiotics, we should always think of rickettsia, which has highly increased in the last decade. And maybe it was previously undiagnosed, but nowadays it has come to our mind. Thinking of the classical epidemic typhus, which was originally has been historically stated to have been affected the Napoleon's army in the history. So that was epidemic typhus. But nowadays what is affecting this part of our Asian countries is typically the scrub typhus, which is spread by rickettsias, and it is spread by the Tsutsugamushi mite and the typhus. And the vasculitis, even KD, Kawasaki disease, which is the most important cause of vasculitis in children and the most important cause of acquired heart disease in children, is Kawasaki disease. And this can also present with a maculopapular rash along with rickettsia, bacteria, and viruses. So this is a very, you can take a snapshot of this thing, like how we can differentiate measles from rubella. Rubella is also known as germ measles, and measles is known as rubeola. Measles rash starts from face and behind the ears and comes to the trunk. It's a very itchy maculopapular rash, but rubella is not that itchy. On the other hand, Previously what we used to see in children is the classical cochlear spot, which is a small blue colored sand like one particle which is exactly seen opposite to the second molar tooth. That comes in the prodromal phase of the measles. And we also get that classical Combi sign, which is nothing but the desquamated gingivitis, of the gingiva, the gum. On the other hand, rubella can present with Forchima spots. Forchima spots are nothing but petechies, like small bleeding areas, around the palate. Measles, a very important MCQ. Warthin-Winkeldy inclusion body is classically seen in measles. So that is how we remember, and that's why I have given a photo of the submarine, because many similar rashes develop in submarines. This is a very important mnemonic, and I think it will be helpful to all of you. Many similar rashes develop in submarines. Many stands for measles, which is rubella, the first disease. Scarlet fever, second disease. Rubella or the German measles, third disease. Duke's disease is also known as the fourth disease. Erythema infectiosum is the fifth disease, and exanthema subitum is the sixth disease, or the roseola infantum. Roseola, it means the infant becomes very pink in color after the rash, and that is why it is known as the roseola infantum. And these are the things, like many similar rashes develop in submarines. This is very important. First disease, sixth disease, third disease, fourth disease, fifth disease, and the sixth disease. Now, how to remember rashes according to the day of appearance of the rash. Now, don't confuse it with the previous slide in which I have shown you guys the diseases. This is the name. First disease means measles, but measles virus doesn't cause rash on the first day. It comes on the fourth day. So this is a different mnemonic. These are only two mnemonics you should remember by heart. Very sick persons must take double exercise. This is a very age-old mnemonic in which you can remember how exactly on which day the rashes appear, and from that we can get a clue to conclude our differential diagnosis. So very sick persons must take double exercise. Very stands for varicella zoster, which is nothing but our chicken pox, which classically has that rose petal-like blisters, which comes on the day 1. Sapia, scarlet fever, which I have already shown you, which is because of the streptococcus, sandpaper-like rashes. Scarlet fever on day 2. Pox, it has already been eradicated, but previously it used to come on day 3. Measles comes on day 4. Typhus, rickettsius, I have already mentioned the scrub typhus, which is very notorious nowadays, or maybe it is more increasingly getting diagnosed more nowadays, comes on day 5. Appropriately, dengue rash. Dengue can have a presentation of rash, fever with rash. The thrombocytopenia parts, everything we already know, but yes, it can come on day 6. The rash typically comes on day 6, and of course, the enteric fever is nothing but the typhoid, which presents with eosinopenia, lot of step ladder like fever, relative bradycardia. Enteric fever normally presents with a late rash, and it is very insignificant. So normally people do not see it, or you need to see it with more keen eyes, and we have to be very careful in the patient. So these are the 5th and 6th diseases. So why I have shown you is because this is a very thing that people get confused with. So the 5th disease is the erythema infectiosum, and the 6th disease is exanthema subitum. These are the two different things. But let me tell you guys, 5th disease is caused by parvovirus B19, which is the DNA virus. And in parvovirus B19, that is on the right hand side, we get a bilateral slap cheek appearance. As you can see in the picture, bilateral slap cheek appearance in the stage 1, and later we can see a lacy reticular rash in stage 2. A lacy reticular rash. in stage 2. It comes later in stage 2. And this virus, parvovirus B19, is very notorious to cause aplastic crisis. Means it will cause a bone marrow suppression, and that will lead to anemia. Even fetal therapies have come nowadays for this erythema infectious, that is a plastic crisis of the parvovirus B19. On the other hand, the exanthema subitum is also known as roseola infantum. This is caused by human herpes virus 6. So that is why it's known as sixth disease. And surprisingly, that is why I've written the subitum will surprise you with a surprise rash, because when the fever subsides, the surprise rash develops. That is why it will surprise you. Nagayama spots are classically seen at the uvulopalato-glossal junction. The subitum will surprise you with surprise. That's what I said. So let's go on. So again, we have already explained this thing. Many similar rashes develop in submarines. Now let's go on the details like the rubeola, rubella, and the roseola infanta. Classically, this is a cartoon that will help you. Come to the dengue. Dengue is the NS1 antigen, the non-specific antigen, comes first. That's what we diagnose it first. And later the IgM, that is the IgM antibody, comes later. The ELISA test is a more specific, and we can't rely on the card test. The management is symptomatic. No need of giving platelets, because this is a very normal thing that the residents normally ask me. But yes, we should not give platelets so often. There are specific guidelines for giving platelet transfusions, and that is not how you should do it. But yes, you have to be very careful, because dengue can present with a severe dengue form with multiple systemic involvement like vomiting, diarrhea, and it can also lead to hemodynamic instability. That is why you should keep on checking the blood pressure of these patients. You should be keeping these patients properly hydrated. That is very important, because dengue can present with dengue hemorrhagic shock also, practically when it is the second episode. So fluid management is very important, and that is already seen in the you can see that in the textbooks. So again, I have already shown you this picture. So very sick persons must take double exercise. So let's come to the maculopapular rash. We have the epidemic typhus, endemic typhus, and the strep typhus. We have the Rocky Mountain spotted fever group of fevers, which is OX2 positive. This is the basics of the Weil-Felix reaction. Coming to the other rashes, this is the allergic rash, which is the urticarial rash, and we have the diffuse erythematous rash. Classically, we get in the KD, which is the most common cause of acquired heart disease in children, that causes coronary aneurysms, and the scarlet fever by streptococcus. This is the classic strawberry tongue and the pastia lines in the mouth, and we can see the classical sandpaper like rash mostly on the chest area, and it is also erythematous type of rash caused by group A beta hemolytic streptococci, most common in school going children. Streptococcus can be divided into alpha hemolytic, beta hemolytic, and gamma hemolytic. Gamma is nothing but the enterococcus. Beta hemolytic has been further grouped under Langsfield into the group A Streptococcus pyogenes, rheumatic heart disease PSGN, and the virulence factor is the pyrogenic exotoxin that causes scarlet fever. And we also have Streptococcus agalactiaceae, which is very notorious to cause neonatal meningitis. And the alpha hemolytic Streptococcus has the Streptococcus viridans group, which is important for causing community acquired endocarditis, Streptococcus viridans. And pneumococcus, as we all know, is the most common bacteria which causes pneumonia in children. It is basically an alpha hemolytic streptococcus. Coming to Kawasaki disease. Normally, what we get in Kawasaki is very important. We get a non-purulent bulbar conjunctivitis, and we can get a unilateral lymphadenopathy, but it is the least common symptom. This is a very important MCQ too. And in Kawasaki, we can get that strawberry tongue and involvement of the mucosa. So we can get perioral excoriations later, and initially we will get extremity changes. That is, there will be erythematous hands. There will be swollen erythematous hands, and later in the second week, after the inflammation goes off, there will be excoriation of the fingers. Skin will be excoriating from the fingertips. That happens in the second week after the inflammation subsides. And also in Kawasaki disease, the most important complication is the aneurysm in the coronary artery. That is why we give immunoglobulins 2 grams per kg IVIG. That is the ideal treatment of choice. So it is a clinical diagnosis. And of course, there are atypical KDs. So if normally you miss it clinically, then you have to go for the lab investigations to support your diagnosis. Coming to the other rashes, that are the bullous and the crusted impeticos. These are basically caused by staph and strepto. Staph causes the bullous and the strepto causes the non-bullous impetigo. Classically, the non-bullous by streptococcus causes honey-colored crusts, and the bullous by the Staph aureus causes varnish-colored crusts. They initially stay for around 1 to 7 days of time. Coming to the chickenpox, and we would be comparing it with the smallpox, which is already eradicated. Chickenpox causes classically pleomorphic rash. That means the rashes are in different stages of eruption. Pleomorphic. Pleo means in different stages. It causes less scars. It has got a centripetal distribution compared to the centrifugal of the smallpox. And it is classically known as the dew on a rose petal. Appearance may be umbilical. So here lies the question. Is it molluscum contagious? So we should always remember, all that glitters is not gold. Similarly, all umbilicated lesions are not molluscum contagious. Coming to the herpes zoster, shingles. Shingles are very painful because they are along the nerve roots. Sometimes they can be after a chickenpox. A reactivation of the varicella zoster virus, because they stay latent and hidden in the dorsal root ganglion of our nerve ganglions, and later they will present to you when there is an immunocompromised state, as in older persons or immunocompromised children, or children getting immunoglobulins or corticosteroids for other clinical purposes. We can get herpes. This is the Hutchinson sign, that involvement of the eye on that side, and the tip of the side nose is affected. Later, it can also affect the facial nerve. It's known as the Ramsay-Hunt syndrome. Most commonly, the frontal nerve is involved, and the nasociliary nerve, if it is involved, it may lead to blindness. The hand-foot-mouth disease is very important in children because it classically affects the hand, foot, and mouth. Most commonly caused by Coxsackie A, the enterovirus 71. Enterovirus definitely has a more severe course. Coming to the other, purpura rashes. Classically, whenever we see purpuric rashes, Hannasch-Collen purpura comes to our mind. But of course, we should have a history of severe abdominal pain when we have Hannasch-Collen purpura. So that is how it should be. Purpura means a bleeding into the skin. Petechiae are smaller spots, pinpoint areas, and larger ones are known as ecchymosis. Meningococcus can have severe bleeding under the skin, and it is a very dangerous disease. Nowadays, we have meningococcal conjugate vaccine to prevent against this virus, against this bacteria, and this is very important. If it causes, it can lead to severe complications and even adrenal hemorrhage, which is known as Waterhouse-Friderichsen syndrome, and that later can cause adrenal insufficiency also. Hemostatic purpura, as I've already explained, classically affects the lower limbs, and it is almost associated with some severe abdominal pain. That is how it presents to you. It can have hematuria also. IgA is the antibody mediated vasculitis. Basically, there is bleeding under the skin. Erythema multiforme. This is just in this erythema stage, but when it progresses, it might become what we fear as Steven Johnson syndrome. Classically, we can see some target lesions that this. It's not. This is a picture from our wards. Erythema infectiosum is very common infections of our upper respiratory tract is caused by Epstein-Barr virus. It can cause severe inflammation of the upper respiratory tract, and we can see that classical downing cells, sometimes immunosuppressions. So if we get a lymphadenopathy, a fever, not responding to antibiotics, we should think of infectious mononucleosis. Previously we used to have Paul Bunyan, but nowadays ELISA is quite helpful. So this is a quite joke. Is it an atrophied elephant or this is an hypertrophied goat?